So it's my pleasure to introduce our last speaker, Dr. Neal Patel, who works with me in Jacksonville, and he's going to do the critical care literature review. Neal, welcome.
Thank you, Dr. Berger, and thank you everybody for sticking around. I have the task of going through a year's worth of literature in 40 minutes, and we'll try to do it in 30. Sorry if I don't pick your favorite study. I tried to pick topics and really only want to focus on a few, so hopefully you leave home with some changes in your management, or at least some understanding of why people are choosing certain things. And an overview of the topics is here, and I mainly put this slide on here to give you a reference for all the sites. But the main three things I want to focus on is this controversy of the antibiotic choice that we sometimes use in critical care setting, steroids and its role, revisiting that for 10 years later from the Corticus trial, and then the choice of IV fluids, which again, a lot of people are bringing a lot of information and decision-making regarding this. So I am going to use the audience response system, so I'm not sure if you've used it recently, but we have about 4 or 5 questions. The first question is this: 65-year-old comes to your ICU with progressive hypoxemic respiratory failure, has a history of interstitial lung disease, notably, and is on immunosuppression with prednisone, Celsep, and Bactrim. Procalcitonin and white blood cell count are elevated. So which of the following would you recommend for therapy? Levaquin and vancomycin, vancomycin and Zosyn, vancomycin and cefepime, vancomycin, cefepime, Flagyl, and Bactrim, or no antibiotics until a bronchoscopy? And I will say that my questions are not necessarily designed to pick out a correct answer, but rather to get you thinking about what the literature speaks upon these issues. Okay, so we're kind of spread about, and the most common choices, vancomycin, Zosyn, vancomycin, cefepime, appear to be the most favorable. So a little bit of background. We use antibiotics a lot. We know when we delay antibiotic therapy in an ICU setting, patient outcomes are worse. Common organisms which we cover: MRSA, gram-negatives, anti-pseudomonal coverage, and we also know the toxicities associated with this, notably vancomycin with rates of nephrotoxicity up to 5 to 7%, and thus we try to keep our trough levels below 15. This gets tricky, especially in the setting of patients that are morbidly obese, and what is their true renal function and how are we dosing this? More recent reports suggest rates to be as high as in the 40s. And again, this could be from increasing troughs, how we're dosing it, duration of therapy, and then also concomitant use. And in several studies, a majority of patients